بسم الله الرحمن الرحيم. Assalamu alaikum wa rahmatullahi wa barakatuh. Ladies and gentlemen, we'd like actually to welcome you for the third journal club for the Saudi Society for Clinical Chemistry. It's a pleasure to have you all participating with us in this important, I would say, celebration of a highly demanding and a hot topic in the society now, which is related to diet, which is related to health and well-being. The speakers actually will be, first of our speakers is Dr. Abdul Hadi. Dr. Abdul Hadi Bima. Dr. Abdul Hadi Bima is the consultant. Is a consultant assistant professor, clinical biochemistry department of medicine, King Abdulaziz University College, and he's very well known in. I'm having actually loss of connection. Just a second. Can you hear me, everybody?
Yes, we can hear you, Doctor.
Yeah, he's a consultant physician in pathochemistry, professor at the Faculty of Medicine at King Abdulaziz University, low-carb diet expert, keto, Australian Fellow of the Royal College of Pathology, active member of the Saudi Society of Clinical Biochemistry, co-founding and president of Low Carb Society, founder and president of Dr. Hadi, the Low Carb Doctor, co-founder and consultant in Roznama Group and Ziara application, many medical researches and studies. He will be starting our first event, and the first actually topic will be the title will be just a second. The title will be is LDL cholesterol versus other biochemical markers in assessing CHD. Dr. Abdul Hadi.
طيب السلام عليكم ورحمة الله مساكم الله خير وبالخير. It's a great pleasure to join you this night to speak about an important topic. First, I would like to thank the Saudi Society of Clinical Chemistry of having me, and to thank you all who is attending this night. And I hope we're going to present an insightful and useful information. I put the title in the beginning about LDL cholesterol to just combine all the three speakers' aspects. As Dr. Ahmed, I'm going to talk about the LDL cholesterol as a marker for cardiovascular events. Then after that, Dr. Ammar will follow, talking about different particles and size. And then after that, Dr. Rayyan or Mr. Rayyan will talk about the methodology of measuring LDL cholesterol or particles. So there will be like two parts for myself. The first part, then the second part, it will be to conclude. In the first part, I'm going to talk about cholesterol versus LDL cholesterol and versus LDL particle, because sometimes there is a confusion between these phrases. Clinical case, lipid profile. I just present one case as triggering your mind. Then after that, we're going to talk about the LDL particle journey and physiology to understand what is happening for the LDL particle. Then we're going to talk about the comparison between LDL cholesterol and other lipid profile marker in cardiovascular risk assessments. So we will compare the LDL cholesterol with what we have routinely in lipid profile, and also we'll compare it with other routine biochemical marker, which is non-lipid, and to see how the LDL cholesterol is performing in assessing the cardiovascular risk. In the second part, I will just maybe do some clinical case interpretation for the one that I started my talk with, then talk about the statin effect on a small dense LDL and low carb diet effect on a small dense LDL as a modality for treating LDL dyslipidemia, if you like, or managing the high small dense LDL. Then after that, we're going to conclude. So just an important notice, even though that I'm a medical doctor, this lecture, it's not by any means considered as a medical advice. And if you want to apply any of this information, you're supposed to consult your own doctor to help you with that. And I hope I'm going to present something useful to all the attendants. I'm just showing a lipid profile or serum cholesterol level for 49 years old female, and this is what I'm seeing maybe in a daily practice or like in my clinic, who I put her on low carb and high fat diet. This is not a current patient. This is a patient I saw in Australia a couple of years ago, but similar picture I see even these days. So the patient, when she came to the clinic to start and assess her her lipid profile before we start low carb high fat diet, her cholesterol was 5.1. Then that is in February. So after 5 months, this cholesterol started climbing up to go from 5.1 to 6.5. Then it will climb again after another maybe 5 months or so to 8.3 millimole per liter, which is a scary figure if we don't understand it. And that's why maybe sometimes we have a bad repetition about if you are in a high fat and see such a profile, that might scare you and ask the patients and advise her to just stop what she is doing. So I hope by the end of this talk, we're gonna see that even if that level of cholesterol, not that total cholesterol, even if the LDL cholesterol is elevated, it doesn't mean necessarily that the risk is increasing dramatically. So we need to understand a little bit about the physiology for these particles or all these phrases. So I'm going to start with the cholesterol molecule. Usually we hear that the bad cholesterol and the good cholesterol, or الكوليسترول الضار والكوليسترول الجيد. There is no such a thing, cholesterol ضار or cholesterol جيد. There is no bad cholesterol or a good cholesterol, because cholesterol is a cholesterol molecule. So the cholesterol actually, as a molecule, is a crucial molecule in our life. It is in every single cell membrane in our body. It is an important and crucial molecule in your brain tissue. If you have a low cholesterol in these cells or even in your body, you might not be able not only to function, it's incompatible with life. So the cholesterol is a very important molecule. And this cholesterol, because it is hydrophobic, it's supposed to be carried with a carrier. So the carrier is lipoprotein or lipoprotein particles, where there is a hydrophilic component surrounding the cholesterol molecules, especially the cholesterol ester, because it is hydrophobic. So it will allow it to travel in the blood circulation. So we have a cholesterol and we have particle carrying this cholesterol. These particles actually surrounding with protein, what we call apolipoprotein. So we are mixing up, because in the beginning, when we consider cholesterol as a marker, because we see maybe here in our slides, the accumulation of the plaque, which may contain a lot of cholesterol, we start to accuse the cholesterol as a cause for that. Then after a while, we discovered that maybe we're supposed to differentiate between the cholesterol, which is carried by different apolipoprotein as a bad. So there is no bad cholesterol or good cholesterol. There is a cholesterol carried by certain particle which may be atherogenic, and other particle which is actually good for us, like HDL cholesterol. So the cholesterol is the cholesterol. The problem may be with the particle. So we have to have this in our mind. To complete the picture, we're supposed to look at the pathway and the journey for these particles. There is an intrinsic pathway where these particles, which carry the cholesterol, is manufactured in the liver. The first molecule produced by the liver is the VLDL, which is a very big molecule with a very low density. And it has its tags or cards to conduct certain function. ApoB, lipoprotein, which is if you like, the hook which will attach the particles to the receptors when these particles go back again to the liver. And there is ApoE also, which help to the attachment to the receptors. And there is ApoC2, which is helping to depload or deliver after your diet or your meal. You will form this particle to transport the triglyceride, whether it is coming from carbohydrate mainly, or it's coming from your fatty meal. So it will be transported by the VLDL then to the target tissue, for example, adipose tissue or muscle tissue. But if there is something happened after, and as this molecule giving more triglyceride to the tissue, it is start to be more denser. Still, it is a low density molecule, but a little bit denser and smaller because it is uploading the triglyceride. So it will be transformed from VLDL to intermediate density lipoprotein to the low density lipoprotein, from very low density to intermediate to low density lipoprotein. And if this stay in the circulation for whatever reason, which might we explain later on, and if there is something happened with this ApoB lipoprotein, so it will not be able to attach to the receptor. This will make these molecules circulating longer in the blood, meaning that it will be exposed to more free radicals or glycation. And that make it also, because it loses more triglyceride, to get smaller and smaller and denser. And it becomes a small, dense LDL. So first we talk about the cholesterol as a molecule. Then we talk after that with the particle as a carrier for this molecule. And we said the cholesterol is a crucial molecule in your body. You need it for the cell membrane. You need it for your brain. You can't function without cholesterol. So the problem with the particle, then we know that we are reporting LDL cholesterol. So we are measuring the cholesterol in the LDL, trying to figure out the amount or estimation for this particle, which is LDL. But we are measuring the total LDL, and there is subfraction as we see here. And when these small dense ones cannot be picked up by the liver, there is no way to get rid of it except by the macrophage or white blood cells, where it can be engulfed and become foamy cells. Then this will be precipitate, or we can see it there in the plaque. So the cholesterol is just a passenger in this pathway. So even for the recommendation for the assessments, if we come to look for the LDL cholesterol, we see that the evidence, the level for the evidence for using the LDL cholesterol at the level of C. And my personal opinion, that is a very generous level for that marker, because we can see now that there is maybe in the coming slides how other markers that is readily available in our hand, but unfortunately we are not using it, and yet we need still maybe further study. But I think we're supposed to consider to shift from this LDL cholesterol to other things when we look for the guidelines for the cardiovascular disease risk assessments. So as I said, the most atherogenic LDL, actually the small ones, I show you that there is 5 particles. The first 2 is actually big, and they have intact ApoB lipoprotein, which is going to be easily removed by the liver. But when we go to the smaller one, then this will be more atherogenic. And really that what we're supposed to look at and assess, because that is really in a lot of literature. There is no time to show all these studies which shows the correlation, the strong correlation with the small dense and the very weak correlation with the LDL cholesterol. But I just here showing to compare to what we have as a lipid profile in our routine lab. Daily we do this, but yet we still look at only LDL cholesterol, and we are practicing based on this marker. So the correlation between the LDL cholesterol, which is the concentration of cholesterol, is just a proxy to just think about the LDL. With the correlation with the small dense is only 0.4. But if we look even for the triglyceride, which we've been recently, unfortunately, turn our head away from it and consider it like it's a less atherogenic or less important, is actually better correlation with the small dense with the triglyceride in comparing to the LDL cholesterol. And if we are just doing a very simple calculation in our lipid profile, we can increase that correlation by calculation the triglyceride HDL cholesterol. And even for the LDL, HDL cholesterol is better, and the total cholesterol with HDL cholesterol is even better. So we have already a valuable marker in our lab that we might use to replace maybe LDL cholesterol, or at least report it with the LDL cholesterol to give us some insight, better insight, if you like, for the small dense LDL. And I actually have two master students who are conducting the research in this regard, looking at the different cutoff for the age and sex for triglyceride HDL ratio. And we are spreading a survey for the clinical lab in Saudi Arabia, and we just find among about 37 lab they contact, almost nobody, only one lab reporting triglyceride HDL cholesterol ratio, while all other lab they are reporting, of course, LDL cholesterol. And we can see the gap between this and these markers, which is available. It's just a matter of calculation. And actually, when I see my patients, and this basis on this paper, to show that actually as the triglyceride is increasing up, the cumulative percent frequency of having phenotype B, Dr. Ammar will talk about that, is the small dense and the part in the right that is atherogenic, is increasing as if you have the probability increase as if you have a higher triglyceride. And if you have a way to reduce your triglyceride, whether with the physical activity or by maybe diet, and it drop, this make most of your LDL is a big particle. And actually 1 millimole is a good cutoff to differentiate between. So the probability if you are having a triglyceride less than 1 is actually very high that you have a good LDL that you don't need to worry about. But if it is more than 1, then you maybe need to pay attention for these patients, especially if they go for like 1.5 to 2. There's almost no phenotype A or big LDL, and most of it will be like small dense LDL. Not only so we still hang into the things that we used to. It doesn't mean that it is very useful, in my opinion, because we already have something ready and available, as I said, in our lipid profile as triglyceride and as the odds ratio. I will also now compare the LDL cholesterol with other routine marker that we have every day, and it is not even lipid profile. Hello. Hello. السلام عليكم. السلام عليكم.
واضح الصوت دكتور عبد
دكتور عبد الهادي.
اي العفو، معليش قطع النت. هلو. السلام عليكم.
واضح الصوت دكتور عبد الهادي، تفضل.
دكتور عبد الهادي.
ايوه تسمعوني؟ السلام عليكم. عمار يقول واضح الصوت. طيب السلام عليكم عمار، تسمعني؟
وعليكم السلام. ايوه تفضل.
ايوه طيب. Okay, so my apology for this technical issue. So as I said, we are not only comparing the LDL cholesterol with the lipid profile, we are even comparing it with non-lipid marker or biochemical marker like hemoglobin A1C, which is maybe routinely we are doing in our lab. So if we are looking at risk assessments.
انضم معنا دكتور عبد الهادي مرة ثانية.
أنا موجود يا دكتور أحمد تسمعني؟ دكتور أحمد تسمعني؟ طيب عمار تسمعني؟
ايوه الصوت واضح دكتور.
ايوه سامعينك يا دكتور.
ايوه طيب. So back to sorry for this technical issue again. So if we are looking for risk assessment, we're supposed to look at this subcategory of patients where they are actually not yet complaining of a clinical symptoms. So they look at 4,000 individuals at their glycated hemoglobin in non-diabetic patients, actually down to 4.8, which is level which is not considered even pre-diabetes. And they look at the subclinical atherosclerosis using ultrasounds, looking at multi-territorial or multi-arteries in the body. And they notice that as the hemoglobin A1C is increasing, actually these subclinical atherosclerosis is increasing, not only in the carotid arteries, in infrarenal aorta, in the iliac and femoral arteries, and even in the coronary artery calcium scores. There is a very strong correlation between hemoglobin A1C and the risk of having subclinical atherosclerosis. So this is a consensus in all these different sites of arteries, how these subclinical atherosclerosis is correlated, very well correlated actually. We see the p-value is less than 0.001, and there is like a dose effect, if you like, or a continuous elevation of the percentage of those who have a subclinical atherosclerosis if you have a higher hemoglobin A1C, which is a marker for dysglycemia. And if we look closer, when I look at that, and I see that now what we are using as a cutoff for diabetes is above 6.5. And what we consider as the pre-diabetes is 5.7. And when they shift actually from 5.5 to 5.7, which has happened just recently, as a chemical pathologist, I don't like it, because I'm as a low-carb doctor and a chemical pathologist who's seeing patients improve very well, dropping the hemoglobin A1C down to 4.5, 4.4. Why we should consider 5.5 normal and push it up to 5.7, and we are looking for prevention. So I thought that is not maybe a right move, but anyway, that's what they decided to shift with the guideline. So to just illustrate my opinion here, if you look at that subclinical atherosclerosis, it starts to climb after 4.8, which is far away from 5.7. And far away even from 5.5. They have like 20% at that level. And if we leave our patient in the dark, just to catch them whenever we are think that they are starting to be abnormal as preclinical diabetes, which is 5.7, we are actually doubling their risk from 20% to 40%, which is horrible. Why we should leave our patients increasing the risk of subclinical atherosclerosis while we have already now evidence that if you have a lower hemoglobin A1C down to 4.8, you can prevent subclinical atherosclerosis. So this is another marker which is much, much more clinically sensitive, and the positive predictive value and also the sensitivity for detecting the early pathogenesis is much better than LDL cholesterol. Not only this, in the same paper, they look at how many individuals in every category who has no disease at all. As you go, this percentage of individuals who are free of disease, they are dropping down. And also, if you are going up, the number of those who have a serious subclinical atherosclerosis or generalized, not intermediate, it's starting to building up, even if you are not yet diabetic. It's just 6.1. And for this systemic coronary risk assessment, which includes LDL, if you add for every marker in that scoring system, the hemoglobin A1C, you actually increase the percentage of the risk by having hemoglobin A1C in that scoring system. And this is happening even if you have the full predictor there and you add hemoglobin A1C, you still have a better assessment for the risk. So we might consider including hemoglobin A1C in this scoring system. And this is also happening, as I said, for the coronary artery calcium score, and also for the number of atherosclerosis plaque by these ultrasounds. It is just increasing as hemoglobin A1C increasing. So that is in March, just 3 months, talking about hemoglobin A1C. Another paper, a little bit earlier, just 6 months ago, in 2020, in January, we look at the association of lipid, inflammatory, and metabolic biomarker with age onset for incident coronary heart disease in women. So we look at the incident of coronary heart disease in women. And here they are looking at 30,000 women. And the good thing about this, they use multivariable regression analysis, and they correct for multiple factors. They correct for sex, they correct for smoking, they correct for age, they correct even for LDL cholesterol, they correct for BMI. So they see that if you are using LDL cholesterol, the adjusted hazard ratio is just only 40% using LDL cholesterol. So what is better than this? If you're looking at ApoB lipoprotein, because now you are not looking at the cholesterol, you are looking at the particle itself. So that is almost double. This is 40%. This is about 80 or 90%. So the ApoB is better. For that prediction, triglyceride even better. It's about 200% instead of only 40%. And if you're looking for the obesity, is about 400%. If you're looking for hypertension, is about 500%. And if you're looking for metabolic syndrome, because it is encompass maybe a couple of these factors like triglyceride, hypertension, obesity, you are looking at adjusted hazard ratio of 6, which is 600 in comparing to only 40% with the LDL cholesterol. So this is actually showing where we are standing using a marker like LDL cholesterol in assessing our risk of cardiovascular disease. So many things, I don't want to take much of time, but so many other studies shows that actually it's not about even the LDL, it's about the small dense, even in the familial hypercholesterolemia. This is the normal individual. They show that there is a defect in the ApoB B100, which make the LDL5 and LDL4 higher as a percentage in these familial hypercholesterolemia. So even in the familial hypercholesterolemia, it is about the defect in the ApoB 100. Actually, even for the CETP, which is the cholesterol estran transfer protein, we know that it is a factor associated with the small dense, but actually even that if it is this activity or it is in a lower risk, still it increased the risk a little bit. But if there is a metabolic derangement pushing the triglyceride higher, look at the difference between the combination with high triglyceride and low CATP, how the risk is multiplied. So it's not about only the cholesterol, it's not about even LDL particle per se or total, it's about metabolic derangement which push the small dense LDL to be formed. This is also another thing showing that how the small dense cholesterol is much better marker than the LDL cholesterol. I will maybe leave it here. This is the last study I'm showing here in 2005, show that there is almost, if you are looking at the big LDL, there is no increment in the relative risk of ischemic heart disease in comparing if you have a higher small dense LDL. Almost there is nothing to worry about if all your particle or LDL cholesterol is belong to this category. So the story is different, and here we can see that it is very comparable as a level of the LDL cholesterol. So I will leave it here for Dr. Ammar to talk to you about these particles and different size. Then I will get back to you on the conclusion. Thank you.
Thank you so much, Dr. Abdelhadi. Thank you so much. Our next speaker actually is Dr. Ammar Tinkel. Dr. Ammar is an internal medicine physician. He worked before at King Fahd Armed Forces Hospital in the section of adult cardiology. He is founder and supervisor of the scientific committee of the Low Carb Society. He's an expert in weight control and ketogenic diet and lifestyle. Dr. Ammar is going to present to us his lecture about LDL and HDL particle and its clinical relevance. Dr. Ammar.
Thank you دكتور أحمد و thank you دكتور عبد الهادي على المقدمة الرائعة جدا. I'm going to talk about the LDL particles and its clinical relevance. So the objectives of this lecture, of this part, is to discuss the LDL particle size and its association with cardiovascular disease. And I will discuss the factor that affect the LDL particle size and how to improve it. So first, we will talk about the LDL particle size and its clinical relevance. The last paper on this regard was in February 2021 that discussed the small dense LDL as a predictor or a parameter from the prospective Birmingham offspring study. The clinical perspective of this study that they have measured multiple atherogenic lipoprotein parameters, and as Dr. Hadi said, that elevated small dense LDL was the best lipid measure of incident of this risk. This best lipid is not the best biomarkers, but it's the best single lipid compared to other lipid factors. And what are the clinical implications of this study? We have to optimize the small dense LDL level, and how to optimize this not by cholesterol lowering medication only. We have to optimize it through the lifestyle modification and the control of other risk factors. And that may be the most effective way to minimize the future risk. Okay, so the target here is not the LDL cholesterol. The target here is small, dense LDL. Okay, so the study separating the lipoprotein modalities have documented that patients with the atherosclerotic cardiovascular disease were significantly more likely to have a triad. Okay, so they will have an increase in the LDL particle number and small dense, so they have the pattern B or phenotype B, and they will also have a decrease in HDL particle number and large HDL, and they will have also the increased triglyceride. But however, the assessment is not yet adopted by the standard clinical chemistry laboratories. So this is the gap. So if we have the modalities to in every hospital, then the LDL cholesterol will be history in my opinion. So what happened to the LDL particles? So the LDL particles should be 25% of it as protein, 45% cholesterol, 20% phospholipid, and 10% as triglyceride. As we move from the largest to the smallest, there will be a significant decrease in the cholesterol esters and free cholesterol, and it will be significant increase in triglycerides. So whenever we have high triglycerides, we're going to have higher percentage of the smallest dense LDL. And these data explain why there is a strong correlation between the small dense LDL and the triglyceride. So these compositional alteration in the LDL particles leads to decrease in the LDL receptors binding affinity in the plasma clearance. That's why it stays longer in our blood, and it will have less resistance to oxidation. So it will be more prone to oxidation. And this is another study. It was published in November 2020. It was a systemic review and meta-analysis. They said that although that the LDL cholesterol is well-studied risk factor, there is a growing body of evidence that challenges this conventional view of LDL cholesterol because of two factors. The first one is there is individual with normal range of the LDL cholesterol, and they still develop coronary heart disease. And secondarily, we have several observational studies that found when we adjust other lipoprotein, we attenuate other lipoproteins substantially. Adjusting for other lipoprotein, we will attenuate the association of LDL cholesterol. That suggests that there is another novel lipoprotein that may have more discriminatory potential, and that is the small dense LDL, because it will have a more favorable effect on penetration into arterial wall, and their susceptibility to oxidation attracts inflammatory factors, and this increases the probability of atherogenesis. And further, the circulation time of small dense LDL, as Dr. Hadi elaborated, is longer than that of LDL particles. So these LDL particles or small dense or LDL particles have different sizes, and we can classify it even either through density or big diameters or other modalities. And we have mainly, generally, 4 subgroups. Some will say it will reach up to 7, but there's 4 major LDL subclasses: LDL1, LDL2. LDL1 is the large one, LDL2 is the intermediate, LDL3 the small, and LDL4 is very small. And if we have predominancy of LDL1 and 2, then this is a phenotype A, or large buoyant LDL. And if we have LDL3 and 4, it will be a phenotype B. And these will be explained in details by my colleague Rayyan, inshallah. So what are the factors affecting this LDL particle size? How can we better modulate this lipid profile? We will discuss here about the factors other than the unknown chronic conditions that influence the LDL particles. We'll speak about weight loss, carbs, fats, and other factors. So if we have to go back to 2006. So this is not a new subject. Since 2006, and we know these answers. This study has, studied different factors. They studied the different effect of carbs from 54, 39, up to 26, and all of these was low saturated fat. And then he compared between the 26 carbohydrates in the low and higher saturated fat. There was a period of stable weight, and then active weight loss, and then weight stabilization. What happened? This is the complete data. We were going to compare between the 54% carbs versus the 26% carb in a stable weight for 4 weeks. We're going to see that even though we stabilized the weight, there was no weight loss. We had more tendency in the lower carb to increase the LDL1 and better decrease of LDL3 and 4. And if we induce a weight loss after the 4th week up to the 9th week, the effect of weight loss mainly became more visible in the patient in the subject with higher carb. So initially there was no significant change in the LDL3 and 4, but with the effect of the weight loss, we noticed more change in the weight stable, and the low saturated fat, lower carb had no significant change after that. Okay, so what about if we increase the saturated fat when we stabilize the carbs? Then we're gonna see much increase in the LDL1. So the large buoyant LDL, the non-atherogenic one, it will increase significantly without weight loss. Okay, and we're going to see that there are marked decrease in LDL3 and LDL4. And if we induce weight loss after the 4th week, we're going to see further decrease in LDL3 and LDL4. And that's just different between we increase the saturated fat in our diet. Okay, so in summary, in the initial stable weight phase, the LDL peak particle diameter increased with lower than higher carbohydrate content. The 26% carb, low saturated fat resulted in significantly greater decrease in small type 3 and type 4 than did the 54% carb diet. And after the weight loss, there was minimal change in the lower carb, but significant decrease in the higher carb category. So the lower carb intakes associated with also reduced plasma ApoB concentration and reduced ratio of total cholesterol to HDL. So there was another other factors that has been improved, but we're going to talk about the small dense LDL here in details. The reduction was significantly only for the 26% carb diet group, whether it's higher or lower fat. Okay, some will say because we have more monounsaturated fatty acid, that's why we have, these changes. But if you reduce the monounsaturated fatty acid, then there will be no significant change in the triglyceride, ApoB, and total to HDL cholesterol in this 26% group. So this effect, this not due primarily to the higher monounsaturated fat content of the diet. So the higher versus the lower saturated fat, there is a reduction in the small dense LDL were similar in the weight stable. But if we induce a weight loss, we're going to see, more decrease in these more saturated fat. And the higher the saturated fat the diet, the more large buoyant LDL. So we will not have any increase in the smaller dense one. So that's why some will have a fear from the saturated fat, and that's not justified. Not only that, if we increase the dietary carbohydrates, then we're going to have more LDL pattern B. So we're going to have the balance between the level LDL3 and 4 will be higher than the LDL 1 and 2. So if there is no weight loss, it will the effect will be significant. And if there is weight loss, we still have increase in pattern B, but it's much less than before the weight loss. And also in December 2006 was discussed, and that changes in the LDL cholesterol and subclasses are important given the popular concern about this LDL cholesterol response to diet restricted in carbohydrates. So that's why in the general guidelines, they are not restricting the carbohydrates. So that's why they are not looking at these subclasses. They are not giving it much importance. But as we see more and more people are restricting the carbohydrates in the diet, we should look at these details in these individuals. And these and the important result from the work of the previous study was, although the reduction in LDL cholesterol were the smallest in the group that have higher saturated fat, there was greatest increase in the large LDL mass and the greatest absolute reduction in the LDL4 mass. And there was also some changes with the ApoB, and was more significant in the highest saturated fat than the other groups. And the LDL metabolism was favorably affected by higher saturated fat consumption. So what are the influence of dietary carbs and fat on the LDL particle distribution? Interestingly enough, the high carbohydrates, low fat diet can actually increase the small dense LDL. Okay, so intervention studies have shown that in conjugation with the well-known increase in plasma triglyceride with the diets low in fat and high in carbs, such diet can increase the concentration of small dense LDL and gonna reduce HDL cholesterol. And this, when we replace the dietary fat with carbohydrates, we're gonna have unfavorable change in the HDL. So we're gonna have dyslipidemia. What about the very low carb diet, the ketogenic diet, compared to the low fat? So we compare the higher fat with the lower fat. What will happen? These studies showed, we concentrate on the LDL particle size. We see that with the low carb diet, in 24 weeks, the LDL, the large LDL, increased from 78 to 120, and the medium decreased from 59 to 34, and the small dense was decreased from 22 to 4.9. In the low-fat diet, with the from 0 to 24, there was slight increase in the LDL, large LDL. There was, no significant change in the medium, and the small one was decreased. Okay, so you're gonna say that low-fat diet can work. This effect can be explained by the weight loss, because these diets, decrease the calories per day, and that when we had, significant weight loss, that's why we had this effect with the low-fat diet. When the low-carb diet led to greater increase in the large LDL and greater decrease in the medium LDL, and these effects of both diets were favorable. What about if we excluded the weight loss? So this study showed the ketogenic diet in normal weight men. So there was no change in the weight. So will we see a favorable effect in the LDL profile? And yes, for sure. In all these groups, okay, we had the increase in the LDL1, the increase in the LDL2, and decrease in the LDL3, and significant decrease in the LDL4. They also divided these subject to two groups, pattern A and pattern B. So pattern A, we see that LDL3 and 4 has not changed that much, but we had significant increase in LDL1 and LDL2, where in subject that started this diet with pattern B, they see significant decrease in LDL4 and LDL3 with significant increase in LDL1 and LDL2. So we had a shift from the smaller dense one to a larger buoyant one. And we see that there is a lot of other markers that had been improved without weight loss in this study. We're not going to go through it. And if we see the subject who started with pattern A, in the third weeks and the sixth week, we had more favorable effects. So it started with pattern A, they continued in pattern A, but with a larger peak diameter of the LDL. And with the subject who started with pattern B, they had improvement within only 3 weeks of changing to a ketogenic diet. So there was significant increase in total and LDL cholesterol returned to the values that were not significantly different than week 0 at the end of the ketogenic diet period. 7 subjects were pattern A and 5 were pattern B. 3 out of the 5 in this short-term study has switched from pattern B to pattern A. You can imagine these changes. And there was significant increase in the percent LDL, significant decrease in the LDL3 and 4 after the ketogenic diet in pattern B subject. So what about longer-term studies? Are we going to have determinant an effect if we extended the period up to 2 years? Yes, we will see the same effect in the LDL pattern. So we're going to see more LDL1 and 2A, and we're going to see less of the remaining LDL pattern compared to the usual care. And if we see the prevalence before of the pattern A and pattern B before this diet, we're going to see tendency towards pattern A lipid profile, LDL pattern in the the ketogenic group, and there was not that much significant. We see that there's an improvement in pattern A, but there's still a lot of subjects that remain in pattern B. So compared with the usual care, the very low carb diet, a reduced level of very small LDL type 3B and increased concentration of large LDL with no significant change in the total particle and ApoB. So there was not significant increase or decrease or change in the LDL, but there was changes within the subgroup of this LDL. And maybe this can be due to the blood beta hydroxybutyrate. So we have to explore what factor did this improvement and did the switch from phenotype B to phenotype A. What about other factors? So we're going to see these studies, discuss a lot of other factors. I'm going to stress on the positive one. So the phytoestros and olive oil. So if we compared refined olive oil with a high, polyphenol content of olive oil with the high polyphenol olive oil, we're going to see significant reduction in the small LDL. And interestingly enough, that with the refined olive oil, there is significant increase in the small LDL particles. So there was, increase in the large LDL in both groups, but the refined olive oil had an increase in the small dense LDL, and that is, problematic. So we don't recommend just olive oil. We have to choose a high quality olive oil. What about fibers? Are phytoestrols, more effective with or without fibers? We're gonna see in the comparison study that if we added the phytoestrols to the fibers, we're gonna see reduction in the medium small LDL particles and increase in the peak LDL particle size. Where if we took only the phytoestrols, the esters, then we're gonna see no difference between the groups. What about EPA and DHA, the omega-3s? Omega-3s in multiple studies had no significant change in the LDL particle size. There was changes in the HDL, yes, but regarding the LDL particle size, there was no significant change. Regarding the fruits, not all fruits are equal. So if we see the avocado, then we're going to see that in randomized studies, they allocated to either avocado diet, low-fat diet, or moderate-fat diet. The LDL particle number and small dense LDL were significantly lower with the avocado diet. So just adding an avocado to our diet will have a significant improvement in the LDL particles. And LDL particle size was reduced in all diet, but compared with the low-fat diet, the avocado diet leads to significant rise in the LDL particle size. So if we see this study, actually, with the small dense LDL particles, all diets had an increase. It was a low fat and moderate fat and with avocado. And to eliminate, to a better extent, the effect of these low fat and moderate fat diets, we add avocado, and this will minimize the production of small dense LDL. So the low fat diet is not optimal for the small dense LDL according to this study. What about other, this is a citric fluid, bergamot supplementation. So with this supplementation, there was significant reduction of small dense 3 and 4 and 5. And there was, after only 120 days in other studies, it's also showed significant reduction. What about nuts? So not all nuts are equal. So if we add like pistachio and hazelnut to our diet, we're going to see a small reduction in the small dense LDL. What about almonds? One study showed that if we add only almonds to our diet, there will be no significant effect. But if we combine the almonds with cocoa and chocolate, compared to the average American diet, there was a significant reduction in the small dense LDL particles. What about the Mediterranean diet? So if you compare the Mediterranean diet, with the high extra virgin olive oil, and if we take the same diet and we added nuts, 35 grams of nuts per day, and we follow up these patients for 1 year, then the subject with Mediterranean diet and nuts has significant reduction in medium, small LDL and very small LDL, and significant rise in the LDL size. The SDL, small density, the small dense LDL particle decreased significantly compared with the control group. So these are the data that showed, significant change. So we're going to see if we add olive oil is not enough to reduce the small dense LDL, we have also to introduce nuts to our diet to get these effect. I'm going to talk briefly that there is also other non-statin medication that gonna improve this, lipid profile, like the dapagliflozin. It was used as a treatment for type 2 diabetes. It inhibits the glucose uptake in the kidney that will lead to increased excretion of this and lower blood glucose in diabetic patient. It showed that it gonna, improve the cardiovascular risk, and it prevent cardiovascular event. And why is that? Because several clinical studies showed that these agent decreases the triglyceride, increases the HDL, but interestingly enough, it increases the LDL. So the question was this increase of the LDL cholesterol might increase the cardiovascular risk? I think you know the answer by now, that even though LDL was increased in subgroup, but the small dense LDL was reduced, and the improvement or the increase was in the large buoyant LDL. That's why we have a net increase in the LDL cholesterol. So these agents suppresses the potent atherogenic small dense LDL. So it's the main factor for this one is to reduce the glucose, but it has also an effect in the lipid profile. That means if we improve the glucose, not with these agents, I mean, if we improve the glucose, as of with the previous studies, we're gonna improve and decrease the atherogenic small LDL cholesterol, and we're gonna increase the HDL2, and these are favorable cardiometabolic markers. And although, as we say, the LDL cholesterol are elevated, it's mostly of less atherogenic large buoyant LDL cholesterol. The take-home message here is that LDL cholesterol is not the best indicator of cardiovascular disease and shouldn't be used as a single risk factors when all other risk factors improve. And if you want to use LDL to predict cardiovascular risk, we should at least measure the LDL particle size to determine the phenotype. And medication alone might not work. We see that every dyslipidemic patient, we start him on a statin without changing the other factors. And we see now to reduce the small dense LDL, we have to introduce lifestyle modification through lower carb and or higher fat, even the saturated fat. Even without weight loss, we can achieve better LDL particle. And weight change is a major factor in LDL particle shift. So we should consider better food choices to modulate lipid profile, because different kind of fats have different effect on LDL particle. Even also different kind of fruits. We shouldn't say that all fruits improve the LDL particle. Certain fruits, mainly the one who had low glycemic index, or like avocado and strawberry, that may improve the LDL particles. And different kind of omega-3 have different lipid modulation effects. So it will not improve the LDL per se, but it will improve the HDL. So it would work in tandem with other changes. And we have to look at the whole profile, please, not just the LDL cholesterol. And thank you.
Thank you so much, Dr. Ammar. Really appreciate it. It's a great presentation. Our next speaker actually is Mr. Rayyan Al-Sulaimani. He's a laboratory specialist at King Abdullah Medical City. He's a weight management specialist, ketogenic diet, and intermittent fasting coach, founder and member of the Low Carb Society Group.
The next talk will be with my colleague Rayyan. I'm waiting for Dr. Ahmed to introduce him.
Can you hear me? Can you hear me?
Yes, we can hear you.
Yeah, okay. Yeah.
I think Dr. Ammar did not hear you.
I think Dr. Ammar did not hear me. Yeah, okay. So he's, I'll repeat again, Mr. Rayyan Al-Sulaimani, laboratory specialist at King Abdullah Medical City. He's a weight management specialist, ketogenic diet, and intermittent fasting coach. He's a founder and member of the Low Carb Society Group. He's a recipient of King's Medal, and his topic will be new approach in LDL measurements. Mr. Rayyan.
Thank you, Dr. Ahmed, for your introduction. And thank you, Dr. Hadi, Dr. Ammar, for your informative and excellent talks. Now I'm going to talk about the LDL measurement. This is the outline that I'm going to talk about: the introduction and the standard lipid testing, direct lipid testing, and LDL cholesterol versus LDL particles, and advanced lipid testing, and LDL particles testing. First of all, we're gonna talk about it's like an introduction. What Dr. Hadi said and Dr. Ammar said, LDL cholesterol is not the enemy here. We should know which kind of LDL that we are looking for. First of all, we will talk about the standard lipid testing. First one of them is calculated LDL cholesterol and direct LDL cholesterol. For calculated LDL cholesterol, this is what we use in our labs. For the LDL cholesterol, we usually do not measure it directly. We measure it, we calculate it by some equations. First one is the most used around the world is the Fredwald equation. The equation it's the LDL cholesterol equal total cholesterol minus HDL cholesterol minus VLDL cholesterol, which we as Fredwald measure it, he estimated dividing triglyceride over 5. So this is the problem with the Fredwald equation. He puts constant factor as a 5 that mislead the result. So for the high triglyceride or the low triglyceride, the VLDL will not be accurate and the total LDL cholesterol will be not correct. So that's why Martin Hopkins have modified that equation. So he changed the 5 that Fredwald used it in his equation with the adjustable factor from 3.1 to 11.9, depend on the patient who's or depend on the lipid profile of that patient. So the flows in the Fredwald equation was fixed in here, and there is a third equation which is not standardized. It's the D Cordova equation. This is estimating LDL cholesterol by multiplying 0.7516 with triglyceride minus HDL. The other method of calculating LDL or for measuring LDL cholesterol is the direct estimation of LDL cholesterol. First generation methods was using chemical precipitation, which uses some reagent with the centrifugation to precipitate the different lipoproteins. So in that method, we can estimate the total cholesterol and the HDL and the LDL and the very low density lipoprotein. In second generation, they use a method, they call it immunoseparation method. They use polyclonal antibodies which separates the different lipoproteins. Third method, it's the homogeneous assay, what we use now. It's an easy way of testing. It just add the reagent, mix, and read without the need of washing or centrifugation. Maybe an example of that will be the spectrophotometer. Yet the important question is LDL cholesterol really what we are seeking for? LDL cholesterol is not the same. LDL is not the same as LDL cholesterol. LDL particles can be large or small, and the amount of cholesterol contained within these particles varies widely. So for this reason, LDL cholesterol often fails to reflect the number of LDL particles. So if we can see in the picture, for the four particles, each one contained 125 milligram per deciliter of cholesterol. So the LDL is different from first one to last one. So the bigger is the LDL particle, the lower risk. And the smallest particles is the higher risk, even though the cholesterol is the same in each one of them. So why advanced lipid testing? Because what we used to use for measuring lipid profile is not enough to give us a clear picture of what's happening there. So we need to check with each lipoprotein particles to see which one is the good one and which one the bad one. Advanced lipid test is beneficial for established or pre-existing cardiovascular disease or previous heart attack, for diabetes and pre-diabetes, for hypertension, metabolic syndrome, dyslipidemia, residual risk patients, and being overweight or obese, unhealthy diet. Other traditional risk factors include age, sex, family history, excessive alcohol intake, smoking, and stress. Advanced lipid testing. LDL particles, which is the one that I'm going to talk about, apolipoprotein B, lipoprotein little a, HDL particles, ApoA1, and remnant lipoprotein particles, and advanced glycated end products. So to measure LDL particles, this is some of the methods that this is some of the methods for measuring LDL particles, like vertical auto profile, gradient gel electrophoresis, nuclear magnetic resonance, high performance and affinity chromatography, and dynamic light scattering, precipitating method, ion mobility analysis, and monodialdehyde modified LDL by ELISA. The vertical auto profile 2 is the using the old technique with ultracentrifugation. The problem with this method is it cannot determine the real number of each particle. It will show us only the dense, where is the how much is the dense LDL and how much the buoyant LDL. This is the most used through the board, the Guardian-Gill electrophoresis. It's a simple method using a gel with a side of a cathode, another side with anode, and they put the sample and put electrical current which move each particle through that gel from the and the smaller the particle, the faster it will migrate through the gel. We can see here like the very low density lipoprotein, the IDL, the LDL, the HDL, HDLB. So in this graph, it will show us that at the left graph, it will show us low risk because the curve is coming in 1 and 2 LDL particle, which is the large buoyant one. In the right graph, it will show us that the peak is in 5, which is the small dense lipoprotein. So in the left, even though it's low risk, but the total cholesterol is 223. But the other one, even though it's total cholesterol is 79, but because of this, the majority of the LDL is small dense, it's considered high risk. Chromatography is another way of measuring LDL particles. The principle is easy. You put your sample in something called, it's like a tube with a targeted binding agent for specific particles. Then we evaluate to remove any particles that we don't need. Then we evaluate each particle in a different container. We can see, as we can see here in the first one, the peak in between 1 and 2, which is which mean this is the majority of LDL is type A, which means the good one. In the second picture, we can see the majority is in 6, which means small dense, which means this is what we call it phenotype B. And another method of estimating the LDL particles, it's nuclear magnetic resonance. Simply, we put a sample. As we know, each molecule has a nuclei. Each nuclei has a proton, which is a positive charge. When we add magnetic field, the nuclei will move in a certain way. Then we add electromagnetic radiation, which move it faster. Then we remove the that electronic magnetic radiation. So the nuclei will come back to its normal rotation, and that will emit energy that we can detect by a detector, and that emission, we can measure it for each particles, and it will give us the size and the number of each particles. This is a result of NMR. We can see in the first row, LDL particle is 1600, and LDL cholesterol is 90 milligram. So we can go like comparison in here, LDL particles with LDL cholesterol. We can see the particles go in here, and LDL cholesterol in here. Sorry, I don't have a pointer to show you everything. You can go in LDL and HDL particles. We can see in LDL size that for that patient, the LDL size, it's in the large, in the pattern A, which is good. And that's it. Thank you for your attention. Now we'll come back to Dr. Hadi.
Yes, hello. Thanks, Mr. Rayyan, for your presentation about the methods. We just want to conclude and make it a little bit, maybe wrapping up. Dr. Ammar, he talked a lot about different option of how you can improve your small dense LDL by having different maybe type of foods in your maybe menu or your plates, like having avocado or like having nuts or whatever. So there is many options of managing LDL dyslipidemia, but I'm gonna just touch in two popular ones nowadays. So for this, back to the case that of 49 years old female who is in low carb, high fat diet. As I said, the cholesterol in maybe about 1 year, it climbed sky high to 8.3 from 5.1, and even the small, the LDL cholesterol jumped from 2.5 to 3.9. But is that really an issue? As I mentioned, you can treat these patients with the statin, and actually statin, the reason that it might show some beneficial effect as a protection, because it can affect the small dense LDL cholesterol, but it is a medication which has its side effects, and then the guideline that you're supposed to use maybe in that patients statin, because according to the guideline you have to start a statin, but under statin it might affect the small dense LDL. But is it small LDL which is elevated in these patients? So if we look at the profile again, we can see since she started on low carb, high fat, actually the lipid profile in other regards than cholesterol and LDL is improving a lot. So from 2.23, the HDL become and climb to 3.4, and from 3.4 it climbed to 4.09. And I never see any patients by any medication or any other mean other than low carb, high fat to push that HDL to 4.09. And I'm asking our colleague if they come across any results similar to this by the effect of any medication. I would be glad to share that information because I don't think there is any medication can push the HDL to that level, which is a very protective molecule. So the triglyceride is dropping, or at least stay as is. Not as is, sorry, it was dropping, and the HDL is improving. So the triglyceride HDL is improving, and even the cholesterol HDL, which is a much better predictor for small dens, as we present in the beginning. It is actually very good comparing to LDL cholesterol. Other options, which is nowadays you might hear a lot about the low carb or keto diet or whatever. If you are applying this right under medical supervision, you might have a total cholesterol for 8%. So, this is what is usually happen for those who is in low carb, high fat diet. After a while, the total cholesterol actually improve, and even the LDL cholesterol is improving. The scenario that I showed just now, it is on cases that we called hyper responders. So it's not always that the cholesterol is going up. I just show that case to tingling. Maybe you're thinking about the high fat, low carb, but actually most of the patients after a while, the total cholesterol, and this is actually based on studies, shows that after 12 weeks of low carb diet, meaning about 3 months or 4 months, you can see total cholesterol is falling down, LDL cholesterol is falling down, triglyceride is falling down about 40%. It's a huge drop. And that is a good indicator, as we said, that your small dens actually is full. And if you measure small dens with the advanced lipid profile testing, that what Ryan showed by chromatography, for example, you will see that, and it is evident. And I do some experiments with some of my patients when I was in Australia, showing that the small dense LDL actually by chromatography is falling. And according to the study, it is falling by 3%, 30% without the muscle ache, without the brain fogginess, and all these things. And actually, of course, weight loss of 7.5 and visceral fat is, which is the most important fat you would like to lose, is your visceral fat is falling by 20% following the low carb, high fat approach. By this, I would conclude, and thanks for your patience and staying with us, 1,700 individual listening to us for this long presentation. Thank you. Dr. Ahmed.
Thank you so much. Thank you so much, Dr. Abdul Hadi. Thank you, our eminent speakers, and would be glad now to have from the audience, if they have any questions, will be welcome.
I don't know whether they write it in the chat or.
Dr. Abdul Hadi, I have a question for you, please.
Yes, please.
It's really nice. It's really nice to correlate, science always with clinical practice. As you know, most of hospitals will do a lipid profile. Usually, lipid profile will show you total cholesterol, will show you actually HDL, and will show you triglycerides. Okay. Now, the point is, and some of them actually what they will do is, like, from the total cholesterol they subtract the HDL, and the others they call it just non-HDL. And now actually we're hearing that the small particles of before it's like the VLDL, the very low density and so on, which really matters. It's not like just any particle. Now, to make research coming into clinical practice, transforming it into like small details of follow-up, do you think actually this will be in the near future, or this would really need to take some time till we focus more on the particular part of the lipid, which is the small dense?
Thanks for the question. It's a good question, actually. And I think I would like to thank Saudi Society of Clinical Chemistry to allow us to just like share this information that we are talking about, to make people aware that, as Dr. Ammar said, maybe it is time to just consider LDL cholesterol as like a not suitable marker, not that specific to look at, and maybe become obsolete in a near future. So this sort of activity, I hope that it will spread. The data is there. In my practice, I am not a supervisor for a lab or a head of a lab yet. It will be soon, inshallah. Definitely, I will implement reporting triglyceride HDL ratio or total cholesterol HDL ratio, because this is, as we been speaking, is a better marker. So and this is a call for all the clinical biochemists to consider, because as I said in my presentation, my students, we are just trying to increase this awareness. We are doing a research, and in only one lab among 39 labs that we are contacting in Saudi Arabia who's reporting these ratios. So it is the change for something that you used to use is not an easy task. But if we start to report these things, starting from our labs, that will increase the awareness for the medical doctor for the presence of this better marker. And this will push forward to change maybe the guideline, because I think those who are sitting and putting this guideline, still there is some resistance for some approaches, especially for high fat, low carb. It's just we are always resisting the change. But I agree, more activities and more research will increase the awareness.
Thank you so much. Thank you so much, Dr. Abdul Hadi. Another approach which has been mentioned this time. Now, the attitude of clinicians usually, like when they see a patient with an abnormal lipid profile, is that they would most likely tell them, watch your cholesterol, or try to take less fat and modify your lifestyle just generally, and then actually let us repeat it after 3 months, or probably they might actually repeat it even before that. And the tendency to start statins or any lipid lowering is easier than really spending time on what kind of lifestyle I should do. So probably actually from what we heard, it's really worthy that after such high results, to have another clinic which really takes time, at least 20 minutes or more, explaining exactly what is needed to be done, and explaining that it's not just to be away from fat. It's not any fat, it's the bad fat, and you need to be actually taking more of the good fat and so on. I think till now, our approach is, the dietary part is very limited. Usually people tend to just go on and start a medication. What do you think, Doctor?
I will just maybe also keen to hear Ammar, but I will just comment a very little comment. When I'm in some WhatsApp group where there's a lot of consultant graduate from the same patch, and when I just present or talk about the results for those patients who are even improving renal function, diabetic patients who improve renal function, all lipid profile is improved due to the lifestyle modification, they said, oh, of course, lifestyle is the best approach, and but it's always in the guideline, it's the first line, but who's in those patients is have a commitment to stay with this long-term management of lifestyle. And it come because we are in the public, but sometimes when we are in private, I talk and ask a question in public, like in WhatsApp group, I can't ask this question. I said, how much, if you are blaming the patients, I would like to ask you how much time you are sitting in the clinic where you do the patient, because it's all about education. And when you talk about lifestyle and diet, you need to really be patient and talk with the patient and educate them. So in my practice, I never have a first session with any patients, and I'm a consultant like another consultant less than half an hour. And even in the follow-up, never stay with any patient less than 20 minutes. So if you want to have these results, we have to really implement it in the right way and give the right advice. We have wrong advice with talking about calories, talking about maybe less fat without differentiating between fat, as you said, as a good or bad, not differentiating between good and bad carbohydrates. So wrong advice and very limited time. So the advice is wrong. The implementation of the advice is not appropriate. So definitely it will not work. But alhamdulillah, in the practice, we see a wonderful results. I would love to hear the comment of Dr. Ammar. Dr. Ammar?
ايوه تفضل. Okay, thank you Dr. عبد الهادي for this comment. Okay, يعني صراحة from what I see in my practice, that the problem is the attitude of the doctors and the attitude of the some of the communities that develop the guidelines. They are ignoring the small dense LDL because every study is showing if we increase the carbohydrates, then we're gonna end up with more small dense and more phenotype B. That's why we don't see that much or that many studies in this regard, and they are trying so hard to blind themselves from the small dense LDL, because even though sometimes the statin might not decrease the small dense LDL alone, it will decrease the small and large bind LDL. That's why in some patients we don't see improvement in the cardiovascular disease. We see more and more events because they're ignoring the fact that we have to target the small dense LDL and increase the large bind LDL, like niacin. Niacin, for example, will increase that, but they are moving around the medication, where there is a lot of lifestyle, as I showed in my part, and that there is a lot of lifestyle changes, simple food choices that can make a huge difference within few weeks only. It's like adding avocado, adding high quality olive oil, like adding high quality of nuts, like stopping adding more fibers. These things, these simple measure that it's not really discussed in the clinic, because they don't know how they underestimate the effect of these changes. So yeah, as Dr. Abdul Hadi said, we should spend more time with our patient. As Dr. Ahmed Ayubi said, we should have clinics that concerned with the lifestyle medication that has been individualized and case by case basis. I have many patients who had like genetic or familial hyperlipidemia, and they are using medications for long years with only a little improvement in the LDL, and there's no improvement in the triglycerides or the HDL. We started the low carb approach, the ketogenic diet, and we reached a point where their physician was surprised from this results, because they said, okay, now we should be careful with the statin and we should reduce the dose, and we shouldn't continue in ezetimibe. And I think in one point we're gonna stop all the medication. I have a patient with long years of dyslipidemia, like total cholesterol, high total cholesterol, high triglyceride, high LDL, with medication. And we just did simple measure, and we seen improvement in all modalities, even in the cholesterol HDL ratio, the LDL HDL ratio, in all ratios. I can't present the data because maybe one day I can show the data. It's really marvelous and really wonderful, the changes we see with simple measure in really short period of time.
Dr. Ammar, there is a link between grapefruit, the whole fruit actually, and some people would say, okay, if you can't have the fruit, you can use the fresh juice, but mainly it was related to the whole fruit itself. What kind of link between grapefruit and lipid profile, or let's say cholesterol?
It's all about, I think, polyphenols and fibers. The more the fruit has more fibers, and low glycemic index, because in different studies that showed if we go with the lower glycemic index carbohydrates, then we're gonna see improvement or decrease in the small dense LDL. And if we use the higher glycemic index, then we're gonna end up with more small dense LDL. So I think it depends on three factors. First of all, the glycemic response, or glycemic index and glycemic load. It's about the polyphenols content of this fruit, and it's about the fibers, because all three in separate studies have shown it works in tandem. So it's all about the content. So if we squeeze this fruit, then we're gonna lose maybe some fibers, and maybe if it stayed longer in the out, then it will lose some of its polyphenols properties. So that's why I think there is a huge difference between because there is a study on the strawberries. If we eat a frozen strawberry, there is a difference between it and between strawberry juice. So yes, there is a huge difference, I think, mainly because of the fibers and the polyphenols and the glycemic response of it.
And I think actually the glycemic ratio now is like becoming now, I would say, more popular now, or people are more into the ratio than the index, I guess.
Yes, because it's about the composition of the meal. The composition of the meal could be glucogenic or ketogenic. Okay, and it could be neutral. If it's more glucogenic, it will have, I think, it produce more small, or tendency toward small dense LDL. And if it's more ketogenic, then it will, be toward small or larger buoyant LDL, and it will improve and decrease the small dense LDL.
I guess actually we are not having more questions.
أظن في سؤال إنه هل يتم استخدام العلاجات المتاحة حالياً لاستهداف السمول دنس LDL. Actually, this is has been discussed in many papers that we should target the small dense LDL. That's why they are seeing the effect of different type of statin on the small dense LDL. And there is, as I mentioned, the dapagliflozin. It has better effect on the small dense LDL. It's funny enough because we are eating a lot of carbs. These patients, they are eating a lot of carbs, and we are getting rid of this carb through the urine. So instead of eating more carbs, we should eliminate or reduce the carb. Why we use medication to get rid of the extra carbs? And also the niacin, it showed that it improve or target the small and dense LDL more than any other LDL or lipoprotein particles. So yes, I think it's in the future we're going to see more medication, but I'm not an advocate for medication. I'm an advocate for fasting, because maybe fasting has an effect on the small dense LDL. Different, higher fat, higher saturated fat, reasonable in a reasonable way has a better effect more than the medication alone.
May I add a comment? يعطيك العافية. أنا because he's asking in Arabic, maybe I talk a little bit Arabic وإنجليزي عشان يمكن يكون الجواب كمان شوية أوضح بالنسبة للother audience، لأنه I agree إنه زي ما قال الدكتور عمار، I'm not an advocate إنه إحنا we go على طول على موضوع الميديكيشن. and this is actually أنا بنصح الجميع إنه دائما لما إحنا نروح على short cut والايزي واي ما هو بالضروره هو الويننج واي. الايزي واي ممكن ساعات يكون really ما هو البيست اوبشن، حتى لو في medications is targeting a small dense LDL. what I want to say بقوله as a comment من كل اللي احنا شفناه الان وكثير من studies in my opinion اساسا انه السمول dense LDL الجلايكيتد LDL شو اسمه الاكسدايز LDL، كل هذه الاشياء هي عباره عن ماركر لميتابوليك ديرينجمنت هابينينج او اختلالات ايضيه حاصله في جسم الانسان. فهو من وجهه نظري we need a lot of maybe research وابحاث عشان نكون متاكدين تماما انه هو السمول دنس هو الكليبرت اللي هو السبب يعني. طبعا هو الاسوسيشن اقوى بكثير مع ال LDL شو اسمه كوليسترول، هذا ما في شك، كل الكلام يكون على هذا الاساس. لكن انا I would say انه هو ماركر لانه صاير في ديرينجمنت، والماركر هذا از مور سنسيتيف للميتابوليك ديرينجمنت او الانفلاماتوري بروسيس اللي صاير اكثر من هو ممكن يكون كوز، وممكن يكون ماركر كوز ان ذا سيم تايم. فلما انا اروح اعالج الروت للديزيز اللي هو continuous high glucose level which is very very ايش اسمه يعني factor driving الاكسيديشن process، معناته انا I'm helping to correct الروت نفسه. يعني طبعا احنا it's not the topic here، لكن لو نجلس مثلا نتكلم على atherosclerosis there is a lot of steps happening قبل ما السمول دنس هذا اساسا يدخل تحت الاندوثيليوم عشان يسبب سب كلينيكال اندو شو اسمه اثيروسكليروسيس. يعني في لايرز اسمها جلايكوكيليكس، if you eat high carb هذه تتصحر، عباره عن شعيرات كده خفيفه جدا is a barrier، عشان هذا البارير يدف اي بارتيكل المفروض ما يعدي على البلاد فيسلز. لما تاكل هاي كارب بتشيل هذه اللاير. في فيز يعني انترستنج، انا ما بدي اخذ وقت طويل في الاجابه، بس انترستنج يعني ستاديز بيقول لك انه الووتر اساسا في عندنا فورث فيز، يعني في عندنا الفيبر اللي هو شو اسمه الحاله الغازيه، والليكويد الحاله السائله، والسوليد الحاله الجامده. الحقيقه في كمان يقول لك فورث فيز اللي هو الحاله الجل. هذا يعني الكونديشن اللي في البلاد فيسلز من غير ما نخص في ديتيل، لما يكون في سيرتن انرجي سيرتن شو اسمه ايونز ديستريبيوشن في هيدروفيليك تيوب، يقوم الووتر ده يصير زي الجل. ففي عندنا بروتكشن في الجل، في عندنا بروتكشن في الجلايكوكيليكس. كل دي لما نحن ناكل شيء يزود الفري راديكالز ويزود الانفلاميشن بتضرب، فبالتالي هذا كله قبل ما يصير في عندنا سمول دنس يعدي ويروح للسب اندوثيليوم. فايف وي تارجت بعدين سمول دنس، انا وود سي انا ماي ايماجينيشن انه بعد فتره كمان حنشوف انه والله سمول دنس اوكي كويس واحنا ما ادري، بس احنا وي ار تارجتنج مولكيول هو ماركر لانفلاماتوري بروسيس او دريجمنت. فجوابي انه ما في شورت كات للاشياء، ممكن يكون في شورت كات احسن من شورت كات. If we target small dense is better than target LDL cholesterol, definitely, because we are getting closer maybe to the root. لكن الروت is just improve your metabolic derangement اللي حاصل, which is improved by lifestyle.
Absolutely, absolutely. Before we conclude, I think one of the new approach now, especially at family medicine, is what they call it motivational consultations. We're used to come to clinics when we are sick, when we suffer from something, or when someone tells us, oh, your blood pressure is high or whatever. And the new approach now really is that why don't we actually go there just for a regular checkup? Why don't we go there just to hear something which is not the usual we hear? And that's why, the concept of motivational consultation, when you really actually go there to hear things that you're really ready to apply and to change. People would say, like everyone knows that, you should do certain things in your life, you should really change your lifestyle, etc. But the question is why people do not apply that. Because I guess this is not just like an easy thing to be said, and that's like just a prescription for everybody. I think tailoring data and tailoring approaches and channels of application is very important. And people do have different personalities and different approaches and perceptions. But I think really this is what we should really always focus on. As you said, Dr. Hadi and Dr. Ammar, it's far before being diseased or being pathological. So let's actually go and revert things from the start. And maybe this is not a good news for health insurance companies, because basically, they need customers. If you really turn everybody into healthy ones, so they lose the customers. That's the point. thank you so much. It was a wonderful event, and we hope always to have more activities and events coming, inshallah. Thank you for the audience. It's been a pleasure. The last word for you, Dr. Hadi.
Last thing is just I would like to thank actually Saudi Society to have us as a guest, whether as from King Abdulaziz University or Low Carb Society. We thank again this Saudi Society to adopt us as community للlow carb society. ويعني إن شاء الله بحول الله يعني more events to educate people about diet and lifestyle, because as you said, I think this is the way to go. شكرا دكتور أحمد أيوب لتقديمك ولطفك، وشكرا للحضور. يعطيكم العافية جميعا.
Thank you so much. يعطيكم العافية.
مع السلامة.